We're going to get backwards.
We'll let fire burn them out.
So you're going to get backwards back to the green zone.
Okay, so, all right, so, yeah,
Am
all
I
right.
upwind?
Say again?
Am I upwind?
Uh-huh.
Am I upwind?
Are you upwind? Got it. Because somebody is, and he went first and he got scared and crop dusted, you want to be upwind of. That's a tough crowd. I'm trying to throw a joke grenades.
Hazmat for patient
Nothing.
decon.
Nothing.
Assess them after you've been decon.
Right? So there's a whole process of this, and it's not necessarily safe to rush in, and you can rinse and repeat for any scenario, right? The shooter scenario, chemical exposure, house fire, the fire department's got to control this before I go in, etc. You all okay with that? So stress that I cannot tell you how sad it is for me to be treating health, pre-hospital personnel in the burn center because they got injured too out of whatever else has happened. Okay. Sometimes, and you talk about the downwind part or upwind, I should say. So sometimes it's the fire and the flame, and sometimes it's the smoke. Do you guys feel differently about the top picture from the bottom picture? Okay, see a nod or two.
What was your question?
What was the question?
Do you feel differently, or do different things go in your mind when you're assessing scene safety for this picture versus this one?
Yes, sure.
Okay, fill in the thought bubble for me. What are your thoughts?
The top is worse
Why? Tell me.
because of the smoke. That's all the byproducts of everything in that house is burning off.
It also looks like a multi-family dwelling versus a single-family dwelling.
Okay. So you seem to have like hotter flame, perhaps. Again, I'm not a firefighter, I'm not a fire science expert, but you've got larger volume of flame, larger volume of smoke that now here's the thing, that we can see. So going back to this guy, I know why he's got the suit on and the splash protection for his eyeballs, but he's also got this, the respirator. So I'm just going to offer this. Has anybody responded to a scene that you had a high suspicion that this was a meth lab? Okay. You're smiling, yes, no? No?
Not yet.
Not yet, not yet. Well, see, the thing is, when they call, they're never like, send help, my meth lab is burning down. They always blame it on the Coleman stove or something, whatever, some other cockamamie story.
Well, we thought that's what the explosion was in Hope County. We thought it was a meth lab, but it was actually the guy that was making his own rounds and blew up his house. Our first thought went meth labs.
All right, and so let me ask you this, and this for real, since if some of you have not yet responded to those scenes, let's flesh that out for those of you who have. What is your concern if you do think this is a meth lab?
Inhaling that stuff.
Okay, so one of them, there's several concerns. Anhydrous ammonia. Okay, it's colorless, it's odorless, it's very volatile, so there may be secondary explosions. Also, since you can't see it or smell it, and it's not necessarily the black smoke, then you're some distance away but are downwind but don't know it, and you get a big lungful of that. I've had more than a few firefighters come in, and they weren't lead attack. They were 50 feet away and safe, so they thought, but didn't have their apparatus on and got a big lungful of that, and here's a week on a ventilator. Does that make sense? So trust your instincts, dig a little deeper for scene safety, because the last thing I want is for you guys to be injured too. Make sense so far? Okay. And again, meth labs are a tricky case because you don't know going in. You don't want to find out the hard way. Now, from the primary assessment part, I'm going to say everybody says ABCs. Here's some refinement to that. And I know we're in Fayetteville. Anybody also involved in military or have military spouse? Okay, so this is a lot of this, and current trauma guidelines are directly out of TCCC, so Tactical Combat Casualty Corps, which is, we know that in traumas, the thing that is most likely to kill people immediately or quickly is blood loss, okay? Which is why asterisk here and asterisk there up at the top. So the thought process is, if my laying eyes on the scene or something about the scenario suggests massive hemorrhage is my concern, that could conceivably trump airway. Now you think about this, and forget about burns and trauma, how about witnessed arrests? Patient has a witnessed arrest, they're talking, blah, 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 and then they DFO. DFO? Fell out, extra credit, DFOIC? That fell out in church, that's different, that's different. And hopefully, does it turn into a DRT? Right there, that's a good call and response, all right. So, the witnessed arrest, what is your algorithm? What do you do for the witnessed arrest? They're talking, then they fall out. Okay, for the flesh out CPR, right? So let's assume we get help, whatever, it's a team sport. Now what? You check to see if they have a pulse, fair enough, right? If they don't have a pulse, do you start with rescue breaths? No, so again, the circulation part conceivably trumps the airway part. Does this make sense? In some circumstances, if you think that's the thing, because our thought process in that is their blood was moving, it must have oxygen, let's get it moving again. And massive hemorrhage, for whatever the reason, I have to control that direct pressure, tourniquet, whatever's appropriate. If I don't see evidence of a massive bleed, I can move on with my ABCs per normal. Now I'm going to extend that out to E and say all of my primary stuff, and my version of primary survey is the stuff that'll kill them right now, okay? And if you don't find and address that, you might never get the chance to get to secondary survey business, okay? So we're going to blow up all of these, spending most of our time on the A, the B, and the C, okay? All right, so we've managed airway, okay? I did not see signs or anything suggesting hemorrhage. So then we move to breathing and ventilation, right? Just because I've got the ET tube in, I want to make sure he's ventilating as well, because I'm not home free with this. Because I'm just going to give you some examples from war stories. We have the farmer on his property. He's found down because the wife sees he's running on fire and falls to the ground before help arrives. So what's your thought process for what to help for the farmer who was running while on fire and is found down like a minute later?
This is on fire, life insurance.
Okay, so what else is on fire, all right? If he's still actively burning, let's put that out, agree with that. But in terms of the life-threatening stuff, in that scenario, what would come to mind?
Airway.
All right, why airway?
Because he's breathing as he's running, so he could breathe in.
You could breathe in on the seat.
Yeah, so he may have breathed in the products of combustion, right? So I'm going to offer two different things here that are secondary to like burn injuries. Whenever there's the edema problem, the all swole problem, which that's progressive and it develops over time. Okay, it's not fire, airway closed instantaneously. Okay, there's time for that third spacing we talked about. Door number 2, which we're kind of hinting at, is did he breathe in smoke? Does that make sense? Will the breathing in the smoke cause his airway to become not patent? Not really. There will still be some air movement, but it will be coating all the stuff, getting down to the alveoli, and then the patient's breathing, but their gas exchange is crappy. This is the patient who's breathing, but their pulse ox is in the crapper. Does that make sense? Their capnography is terrible, even though they're breathing, or you're breathing for them with an ambu bag, whatever. Okay. So for a farmer, he was running, he fell. I don't know how hard he fell. That's a fall, slips, trips, and falls if he's running. How old is he? Is there skeletal trauma, cervical? I don't know. That could be a concern too. So in this particular case, first responders get to him and they see that this is probably 15 minutes after he fell down, whatever, the wife called and bam, right there. His blood pressure is 70/40. Okay, so let me ask you this. Blood pressure is 70/40, 15 minutes after burn injury. What do you think? Is it because of the burn?
He's third space.
He's third spacing already.
Okay, so this is a point to really emphasize. Third spacing and burn shock, it's a real thing and it happens, but it is progressive. It's progressive and takes like hours to develop, okay? If this is 10, 15 minutes after the original injury and they're already hypotensive, something else is happening. Figure out what it is. Now, again, you got to figure that part out, but something else is happening. When they started cutting away and realized, they saw the 47 bee stings on his back. Does that make sense? He was burning out a hornet's nest. Accelerant, got on the pant leg, and there you go. But it wasn't the burn that caused the, say again? This was anaphylaxis. This makes sense? So again, I'm not saying don't worry about third spacing. I'm not saying don't worry about burn edema, but I'm saying if this is, because you guys are typically there very shortly after injury, if early hypotension is a thing, it tends to suggest, point strongly to something else is happening overlaid on top of the burn injury. So dig deeper, be methodical in your approach, okay? All right. That we saw. And now this is for benefit. I know not everybody's played the game for decades. And I know pre-hospital, a lot of people end up with a collar when we suspect trauma. I'm going to give you a specific example from history that always stands in my mind when I think about what is the risk involved here. Why do I lean towards that cervical immobilization? My cultural references are becoming more irrelevant over time, which basically means I'm getting old. But if I say Chris Reeve, so who that? The original Superman, right? The 1978 Donner film. What happened to him? So horse accident.
Can't fly,
He was not able to fly. We'll talk about why. Okay. Horse accident, but he didn't die on scene. What happened? He broke his neck. Ultimately was a quad. That really just moved here. He died because of sepsis from a pressure injury, which is like, whoa, sobering thought. I mean, like a long time after the original injury. Now, here's the thing that should give pause, particularly to first responders. And I'm interested in I did for that video, the camel, what is that? The camel?
The lifting system.
Camel lifting, what's the point of that?
So we don't have to take people up off the floor
Prevent
anymore.
back injuries.
Yeah, so protecting yourselves, etc. A kissing cousin to this, or scoop lifts, or other things of this sort, where there's some pretty good literature that says a fair amount of spinal injuries are at least exacerbated by what the healthcare professionals are doing when they respond. And so we want to be very mindful of what we're doing. In this particular case, horseback riding, he didn't want to drop the reins, so he had the reins tightly wrapped around his hands. The horse balked at a jump, and he went over the front of the horse, landed on his head, pulverized, in compression fracture, pulverized C2. Here's the thing that's the most sobering. When people ran up to help him, he was fighting off the people who were trying to help him because he was disoriented, as you might anticipate. He was fighting off, what am I doing with my arms?
He's moving his arms.
He was moving, and that's the scary, sobering part of this, the reason for this. It's nobody's fault per se, but immediately after injury, his spinal cord was intact, even though the cervical vertebral column was pulverized. It was the thrashing around on his part that caused the spinal cord injuries. Does that make sense? So again, be mindful. We don't know. Patients found out that they fall. You err on the side of caution so we don't add spinal injury to other problems. Now, we talked about this a bit, but you have multiple things in your bag of tricks. Basic airway adjuncts, as was mentioned, a oral airway or a nasal airway as appropriate, right? We don't use oral airways if they have an intact gag reflex, blah, blah, blah. Who do you not use nasal airways on?
Facial problems.
Yeah, facial fractures, right? Everybody's seen the scary radiology films where the left turn at Albuquerque and, the NPA goes right up the. I try to focus on the positive. The good news is we're oxygenating the brain really well. Try to find a silver lining there. So yes, basic adjuncts, and then you have your intermediates before you get to ET tubes, as was mentioned, your King airways, next evolution of combi tubes, blind insertion devices, blah, blah, blah. And it's beyond the scope for me to tell you guys how to do that. That's your role, not mine, your expertise. But anticipating early what your concerns are and then acting, using the right tool in the toolbox, so to speak, okay? I don't want to suggest that everybody who's burned always needs an ET tube. That's not what I'm saying. But you anticipate what's happening now and what's going to happen, and you act accordingly. If I look at this patient right here, and again, you don't know a story, all you have is what you see. And somebody's already got a laryngoscope laid on him. Okay? What is it about what you see that causes you to have concern for airway, breathing, and ventilation?
Just sit around the mouth and the nose.
Okay, all right, so let's deconstruct this. We see soot on the nose, around the mouth, and I would, based on solely on what I can see, on the teeth in the mouth. So in the mouth. I would certainly want to, as I'm having my laryngoscope and I'm trying to visualize, is that soot all the way back in the oropharynx? How far down does it go? That's a pertinent question, okay? What else do you see that's worrisome? Because the soot is really a marker for that byproducts of combustion. The soot's problem one, but it points to, was there stuff in the smoke that's problematic for the lungs? Think carbon monoxide, impaired gas exchange, all of that stuff. That's one set of problems. What else do you see that's worrisome?
Looks like he might actually have burns to his face, so edema issues.
And those are the two broad buckets. They're related and often together, but they're not the same thing. Does that make sense? The soot suggests they're breathing in smoke. How far down does it go, etc. And the actual cutaneous injury, I mean, this looks like it's at least partial thickness, i.e. at least second degree. And I don't see the rest of the picture, right, but does it go inside? Edema, there seems to be some right now, but if it gets worse, will I have loss of airway? Does that make sense? So again, the extreme case, an ET tube would address the edema, loss of the upper airway question. The ET tube does not address smoke inhalation. Does this make sense? So again, I want you to have those in separate buckets. If edema is your concern, absolutely. That ET tube would be the definitive way to manage that. But it doesn't, you might need it, but it doesn't solve your problem for the inhalation. Okay, so these are concerns that we have. Let's keep rolling. Besides edema, obvious airway edema that is either present already or more to the point likely to come soon, or the inhalation. The other two main reasons for intubation, I mean, the first is obvious. If they're already in respiratory distress, that might buy them the tube right there. But this one's the least intuitive out of the bunch. If I was burned only from the waist down, nowhere near my upper body, nowhere near my face, neck, etc., burned only from the waist down, the first minutes to hour, 2, 3 after injury, I have got no airway issues. But what am I going to do for a 40, 50% burn? They're going to give me a metric crack ton of crystalloid, right? Here's LR, LR, LR. Does this make sense? But I have capillary leak everywhere. What we find is after about a 30% burn, the edema is generalized enough so that 18, 24 hours later, I might have airway compromise even though that wasn't where the burn was. Does this make sense? Now, that does not mean you need to tube them in the field 15 minutes after injury. Does this make sense? But you anticipate, well, this patient, if you have a chance to talk to him, here's what's going to happen. There is a chance that blah, blah, blah. But we know all the fluid that I'm pouring into the blood vessels is leaking out into the tissue. So that generalized edema is coming from me pouring water into a leaky bucket. But I got to do that. Okay. So going back to the difference between the two broad buckets that I'm concerned about, the imminent loss of airway from edema and the inhalation. Again, two problems related, but they're separate problems. What we find is, broadly speaking, the thermal insult tends to be above the glottis, the actual thermal injury proper. Because up to this point, that's a pretty efficient heat exchanger, so excess heat bleeds off. The one exception, sometimes like cases of steam in industrial settings, steam has a heck of a lot of heat energy, so you may have lower airway thermal injury with steam. But broadly, we don't typically have lower airway thermal insult. What's the problem for lower airways? It's stuff in the smoke. It's stuff in the smoke. The aldehydes, the sulfides, the carbon monoxide, the cyanide, all that stuff. Okay. So whoever's doing the visualization here to pass a tube, because they were worried about edema threatening their airway, this is what they see. Now I'm going to say depends on how you slice this, there's at least 3 problems with what I visualize here. Nobody's thrilled about trying to pass a tube here, pass the cords, because I can't see what I'm doing. Because of the soot, right? It's wet soot business. The other part to notice is the actual appearance of the mucosa here. This looks pink, friable. Looks like I have mucosal injury as well from the heat. Does this make sense? Now, complete parenthetical aside, I'll just ask, I don't know, and I'm not trying to teach you guys how to intubate. That's your expertise, not mine. Has anybody heard of, used salad technique? I'll offer it just as something to investigate when you're worried about lots and lots of secretions or aspiration risk, or you think they're just going to have that lava flow of gastric contents or whatever, or you're just worried about all that. It's an acronym. It's suction-assisted laryngoscopy and direct visualization. So the idea is it's a whole technique. If you just type in salad, all caps, salad intubation, there's training videos. It's interesting. It's a way to increase your first pass success rate. If lots of contamination, suction-assisted laryngoscopy and decontamination. It's the whole point is to lead with the Yankow or the hard suction catheter so that you don't gum up or hoover up the light on your laryngoscope, or if you're doing video assist, the fiber optic camera. That's a parenthetical aside. Here, I'm interested in the edema, making intubation later problematic. I'm also concerned that soot there doesn't go further. Does that make sense? What I'm really worried about is soot, because if I can get the tube in, the edema is no longer my concern. If I can get the tube in for the edema perspective. But what I'm really worried about is this. Okay, because if the soot goes beyond the glottis to the distal airways. So how far does the ET tube go?
Just the same correct.
It goes 2 to 5 centimeters above the carina, right? And if you get a little happy, right main stem, whatever, but you pull back above the carina, okay? The smaller distal airways, I don't really have a convenient way to suction that, right? Like if I want to get stuff in the distal airways up, I have to have a cough or I need something else. In this case, has anybody seen a bronchial lavage? If you've maybe transported someone to an ED, okay? The idea is they just take a fiber optic camera and they're sliding that down the advanced airway. It works with an ET tube or a trach. And they're going past the carina, and they keep going down to split after split after split to get into the smaller bronchioles further down. So I am well past the carina at this point in time. And this is my first look-see. And I see all of this soot way down past the carina, okay? So that's problem one. They go ahead and wash it out, lavage. They squirt out some sterile water, then slurp it up. It has suction attached. And I try to wash off some of this soot. A couple of days later, 4 days later, I see less soot and more visible mucosa. Between day 4 and day 5, I see a little bit less soot, and then I start seeing this business. What is this diagonal stuff?
Is it effusions?
Not effusions per se, although you are worried about effusions, because again, the permeability of the lungs is going to be quite high, and they may end up with robust pleural effusions. Absolutely true. The analogy I'll make here, because this is from the mucosal surface, has anybody ever had a sunburn? What happens 4 or 5 days after your sunburn? You start peeling. This is exactly the same thing. However, this was not thermal insult. This was chemical insult. All of the crappy chemicals in the smoke causing cellular injury to the mucosa here. 4 or 5 days later, it starts sloughing off. This is indicative of how far down the damage is, not just heat, but the bad stuff in the smoke. And if it's this far, what you're really worried about is that it's that far, all the way to the alveolar level. Has anybody ever had a patient who they were ventilating, or you were ventilating for them, but their oxygenation was still crappy? Okay, what kind of patient? Give me some. Say again?
COVID patients.
Boy, yeah, that's a classic case, right? So what's going on among many other things? Because my God, it's like a whack-a-mole for COVID. We keep finding other organ systems that are impacted, or it's beyond just a lung problem. There's multiple dimensions. But it's the diffusion, right? This is like a special flavor of arts where I just can't. I can get down to here, but I can't diffuse across. That's a whole different set of challenges. So just to be clear, I've talked about ventilation. All that means is outside gases or air can reach the alveoli. That's all that means, okay? That's step one. If you can't get the outside air here, then we know gas exchange won't happen. But that's step one. I at least have to have ventilation. I gotta have patent upper airway, patent lower airway. Let's just think outside the box. Can you think of a situation where the patient had a patent upper airway, but lower airway patency was your issue? Okay, what kind of patients?
Had a nosebleed patient one time.
Wow.
She aspirated on the blood.
Okay, well, there you go. So, right, aspirations for like profound epistaxis, dang, heck of a lot of blood, right? So lower airway, and it could be secretions, could be pneumonia, could be, again, think back to the bee sting person, right, the old farmer, right? Could be bronchoconstriction, could be fluid, we talked about that as well. So all that to say, upper airway management doesn't solve all of your problems. It's necessary, but you could still get stuck with lower airway problems. At the end of the day, how do you know whether you're ventilating your patient or not? Okay, so capnography, which we are going to absolutely talk about. If we don't have the capnography hooked up yet, how else might I know whether I'm ventilating my patient? Yeah, so we'll keep it, before we get to the capnography, we'll keep it nice and simple, right? Look, listen, feel. Do I see rise and fall of the chest rise, right? So do I see chest movement? Is it equal bilateral, all that stuff? How else would you assess? I mean, can I hear lung sounds, right? Do I hear the breathing? Do I see the moving, okay? At that point in time, if their oxygenation is still low, but they have good chest rise, what else can you do? Well, going back to COVID, what do you do for COVID patients if they can ventilate, but their oxygenation is craptastic? What other strategies? Okay, that's door number one, or I should say door number two, CPAP. What is CPAP? Continuous positive airway pressure. We're cheating. I can get the air here, but to improve diffusion, a push. Humpty Dumpty was pushed. To try to push it across to diffuse from here air into the bloodstream. So positive, and I'll say CPAP is one flavor of the broader principle, positive pressure. That could be CPAP, it could be a ventilator outright, it could be high flow nasal cannula, it could be my ambu bag. Any of those where I'm actively pushing, okay? What's the other strategy? Here's your nasal cannula or your face mask or supplemental oxygen, right? And that's the two basic flavors, everything you're doing. If you can ventilate, but they're not oxygenating, everything boils down to, well, improving diffusion. You either deliver more oxygen in the first place, or you push it across. Positive pressure or more FiO2s. One of those two. Okay. All right, so let's pick one more case study and we'll take our first break. So some of you mentioned this particular case, and patients you've seen or methods of injury. So what I want to get at here, as we've talked before, you want to use the right tool in the toolbox, and you know what clinical findings you're looking for. What were the two basic things that, with fire and flame, that we're worried about for airway breathing and ventilation for burn patients? What are the two basic problems?
Swell.
Yeah, so swelling or edema, right? That can cause loss of airway. What was the other problem? Think about the bronchial lavage and all of that. Yeah, so inhale, and you usually think of soot as a marker for badness in the smoke, right? It's the stuff that we can't see but soot. So inhalation and edema. So let's think about how that relates to this patient. So they're smoking on HOMO 2, okay? 4 liters per minute. Is that a lot of flow, a little flow? Where does that fit? 4 liters per minute.
It's high for nasal.
Say again?
It's a lot on the high for nasal cannula. It's not-
Well, sure, that's the upper range of nasal cannula, but how much is coming out of your non-rebreather? 10 or 15, something like that, right?
It's
So,
low flow.
say again?
Nasal cannula is low flow.
Yeah, so but it's like, so it's relative, right? So nasal cannula, we kind of start thinking, what else could I use after 4, 5, 6 liters? But in the grand scheme of things, that's not a ton of oxygen over the course of a whole minute. That leads me to why the picture is what it is. If I look at this picture, because this is your patient. In this particular case, because sometimes it's worse than this, sometimes their clothing catches fire too or something else. But in this case, any guesses why the burns seem to be confined here? Because that's where the oxygen's coming out of the cannula, right? Combustion of that. Are you surprised that there are burns and swelling to the nose? That's right at the epicenter of where the flame is. Are you surprised that they're singeing to the nasal hairs? That is like literally in the path of the flame, whatever, self-limiting flame process would be a flash, okay? All right, so you'll see those things, the edema here. What else are you interested in? This is where you want to be thorough in your assessment. What's inside the mouth? So can the patient follow directions? That's great, right? Or how are they mentating? Can you open your mouth, say, ah? If you look in their throat, would you feel differently about a black sooty tongue versus none? Like no soot inside the mouth? Those speak to kind of two different things going on. Does it make sense? I'm expecting the edema here. I'm more interested in what's happening inside. So, the plan, how many folks want to intubate?
I would like to, but you risk creating more trauma or more swelling.
Well, you could have traumatic intubations, it's absolutely true. And I would say an associated part with the intubation is who's going to be very difficult to extubate. COPDers, classically, right? So, please hear the detailed version of what I'm saying. I asked all 3 of my attending physicians at the burn center, said, look, I'm doing outreach with EMS all over the state. Is there anything you want me to emphasize? All 3 of them, without talking to each other, all 3 of them immediately blurted out, stop automatically intubating COPDers who smoke on home or 2. Now, that keyword automatically. Nobody's saying don't intubate COPDers. That's not the message. But have just a little bit of room for the watchful waiting. In these cases, and when I heard all 3 of them say that, I did a data dive to look at what the literature says, and about 10 years ago, physician statement came out from the ABA and said the overwhelming majority of these patients that look like this, again, I'm not talking about their clothes caught fire and they got 30% full thickness burns and are a crispy critter. I'm saying the edema is to the nose, the lips, but when you look inside, there's no sit inside and they can talk to you. They're not having respiratory distress. Those patients do just fine with watchful waiting. Watchful waiting. Okay? The reason that we pick that out of the mix is once you intubate them, often you're on the hook for that tube for quite a while, and they're at huge risk for pneumonias. So it's not uncommon, the tube is in, they likely did not need it to begin with, and 3 weeks later, now they have a ventilator-associated pneumonia, now they've got a real problem. Does this make sense? Please hear me. I'm not saying never intubate COPDers. That's not what I'm saying. If you hear stridor, here's your tube. If they're having respiratory distress, here's your tube. If you see soot all inside the middle of the mouth, the back of the mouth, if they're hoarse,